An introduction to critical care, presented by me, your host, Pat Nelligan. When we order a portable chest x-ray on a patient in ICU, we are really interested in looking at the hardware that the patient may have in place. These include endotracheal tubes, tracheostomies, various different lines that are central lines or peripherally inserted central lines, chest tubes, etc. So this tutorial is about the hardware that we insert and how to assess it. Chest imaging in critical care, Part 2, Hardware. In this tutorial, I will discuss identifying hardware on chest x-ray and ensuring correct hardware placement. Let's start with breathing tubes. Two types of breathing tube are inserted into the ICU patient. An endotracheal tube on the left of this picture is placed through the mouth or the nose into the pharynx, through the vocal cords, and into the trachea, where it is fixed in place using tape or a strap on the face. A cuff is inflated to ensure that air going in and out of the lungs must pass through the tube. It also partially protects the lungs from inhalation of gastric contents. A tracheostomy, on the right, is a surgical airway that is placed directly into the trachea, usually on patients who have been mechanically ventilated for some time, or those who have had major head or neck surgery. The tracheostomy is shorter, but it also has a cuff. These devices are used to help liberate the patient from mechanical ventilation, for airway toilet, and to protect the vocal cords. In both cases, the tip of the tube must be located in the trachea above the carina. Let's draw in the trachea, the carina, the left and right main bronchi, and the clavicles. In general, the ideal location of the endotracheal tube tip is below the clavicles but above the carina. The tube has a radiolucent strip on it so that you can actually see it through the black and white of the image. We know that it's an endotracheal tube because the tube emerges from the top of the picture. It has passed through the upper airway. If the tube is located in the trachea but does not advance above the larynx, then this is a tracheostomy. Regardless of which type of tube we are dealing with, the tip should be in the same place. There are three common ways of identifying the correct place. With the neck in the neutral position, the tip should be 3 to 5 centimeters above the carina. It should be below the level of the clavicles, and if you can identify it, at the level of the T4 spinous process. This is a chest x-ray of a patient in the ICU. It is very easy to identify the patient's first rib, and we know that the T1 spinous process and the first rib are on the same level. Once you know where the T1 spinous process is, then it's very easy to identify T2, T3, and T4. And that's where we want to see our tip of our tube. In this particular image, you can see that because of the way it was taken, the clavicles dip downwards at a fairly steep angle. So if the tip of the tube was at T4 in this image, it would be above the level of the clavicles, but in the correct position. Look carefully at this chest x-ray. Can you identify the position of the endotracheal tube? Well, here it is. Let's draw in the clavicles, the trachea, and the main bronchi. Well, what do you think? I think this tube is too high and it should be advanced downwards by 1 or 2 centimeters. What about in this picture? There's no question, in this picture, the tube is too high. This is a postoperative chest x-ray. Note the cardiac projection. There are two abnormalities here. The first one is that the actual endotracheal tube is too high. It's a long way from the carina, which can be quite difficult to see. But also, and we'll talk about this a little bit later on, that central line tip is very high as well. In this case, the tube is too far down. It nearly always goes into the right main bronchus risking atelectasis of the left lung and the right upper lobe. This is what an endobronchial intubation can look like. All that needs to happen is that the tip of the tube is lodged in the proximal right main bronchus. The result in this case is complete atelectasis of the left lung. You can see in this picture that the entire left lung is collapsed and the right upper lobe is also collapsed. The cause is malplacement of the endotracheal tube that is in the right main bronchus, distal to the origin of the right upper lobe bronchus. Now let's move on to looking at lines. Central lines are placed in the ICU for a variety of reasons. They're more reliable than peripheral cannulae. They can be left in longer, have multiple infusion ports, and are suitable for vasopressors and total parenteral nutrition. Central lines can also be used for measuring CVP, that's central venous pressure, and doing venous blood gases. There are also specialized central lines for renal replacement therapy. Let's look at the sites for insertion of central lines. Keep in mind that these days most lines are inserted using ultrasound. In the upper part of the body, the most common site of insertion of a central line is the right internal jugular vein. Alternatively, there's the left internal jugular vein, and then the right subclavian vein, and the left subclavian vein. Radiologists may actually insert a porticath or a Hickman line into the superior vena cava, or a PICC line into the brachial vein. In the lower part of the body, central lines tend to be placed in either the right or the left femoral veins. These are commonly used for dialysis catheters. They're sometimes used because we can't get a central line elsewhere or the patient has head and neck trauma. When we place a central line, we usually image the patient afterwards to ensure that the tip of the central line is in the correct place and that we haven't caused a complication such as a pneumothorax. Clearly, there's no point imaging after placing a femoral line, as the tip of the line will be in the inferior vena cava. So on this chest x-ray, I've identified two structures, the right heart border in red and the superior vena cava in yellow. If one places a central venous line, the objective is to advance the tip to the distal SVC just proximal to the junction of the right atrium. In this case, a triple lumen central line has been placed in the right internal jugular vein, and it's in the ideal position. The other site of insertion of a right-sided line is the right subclavian vein. A peripherally inserted central catheter or PICC line will have a similar appearance to this. This is the path of insertion of a left-sided internal jugular line. The lines are radio opaque, so they'll appear white on the screen. This is the left subclavian vein and the track that it will follow to be in position A. In this situation, if you see this picture, the line is malplaced. This is an attempted right internal jugular vein line, but what has happened, instead of it going downwards to the junction of the right atrium and the SVC, it has turned rightwards and gone down the subclavian vein towards the arm. Occasionally it goes like this into a parallel vein that is not clearly heading towards the heart. This is the azygous vein that is sometimes seen in some patients. This is a correctly inserted line, but it's just going too far and it's right down in the right ventricle. It needs to be pulled back a few centimeters. If you look at this picture carefully, you will see that there is a peripherally inserted central catheter and its tip is in the right atrium. Again, it's a little bit long. It can be pulled back. That's why we do the image. This is a subclavian line that's going the wrong direction as well. In this case, the subclavian line is going up into the neck. This is not an uncommon scenario. The other places a subclavian line may go astray is that it may go straight across to the other side. In both of these situations, you need to withdraw the catheter and resite it. This is a left-sided IJ line that's going into the superior vena cava, and while this looks okay, you would really like to see this go a bit further. I don't like this location because it's a high-risk location. It's at a junction, and there is a risk that it may erode into the wall and cause a big hematoma. In this situation, this patient has a large mediastinal hematoma due to a line eroding through the SVC. This is not something that you're going to see very often. Also, keep in mind, some patients have completely anomalous venous activity going on, and this is a central line going to a location that is not identifiable by normal anatomy. Now, aside from the placement of the line and making sure the line is in the right place, there is another thing that you really need to be careful about. And this is what happens. If you had placed this line, you would have been pretty happy that it was in the right location. But there is a problem here, and that is that the patient now has a pneumothorax on the right side. What about this picture? You can see that the patient has a left-sided subclavian catheter, and the tip of the catheter is in the correct position. You may be very happy with this outcome, but look carefully. You can see that this patient has a left-sided pneumothorax. Now let's move on to feeding tubes. Virtually all critical care patients will have a nasogastric tube placed in to either drain the stomach or feed the stomach or deliver medicines, or all of the above. It is not easy to place such a tube in an intubated, uncooperative patient, and not infrequently these tubes are placed in the wrong location. The only way of being certain of correct placement is to perform a chest X-ray, particularly imaging the upper abdomen. Helpfully, the tip of the tube is radio-opaque. The ideal location of a feeding tube is down the midline and into the stomach. If the tube has not passed beyond the diaphragm, you have to assume that the tip is inside the chest. The radiographer in this case was called to do a chest X-ray on this patient who has just had a nasogastric tube inserted. Can you see the tip? You must see the tip even if you think that the tube is going below the diaphragm. So a second X-ray was taken. The patient was re-imaged, just capturing the subdiaphragmatic area, and there you can see the tip in the stomach. Can you spot the nasogastric tube in this picture? Here it is. It's in the right main bronchus. This is not where you want a tube placed. It must be immediately withdrawn and reinserted. In this case, the tube was placed in the left main bronchus. You can see that the tip of the NG tube was placed into the right lung. This was clearly not checked. A nasogastric feed was started, and you can see airspace consolidation. In this picture, you can see the tip of the NG tube in the airway of a very diseased right lung, and this has resulted in a pneumothorax. If you look carefully, the tip of the NG tube is in the esophagus. It had previously been correctly placed, but it had slipped backwards. In this picture, the same patient's tube had been advanced into the stomach. Although this looks like the tube was placed in the lung, it is actually in the stomach because the stomach is in the chest. Have a look at this picture. 2 frames, left and right, and think about what you see. This patient has dense consolidation in the left lower lobe, so this is a lobar pneumonia with extensive airspace disease bilaterally. And on the left panel, you can see that the nasogastric tube has been inserted down the right main bronchus into the lung. That was withdrawn, and then the tube was reinserted, and you can see that it passes down below the level of the diaphragm. And this is good medical care. That's why we do sequential chest x-rays in these situations. Now, let's move on to cardiovascular devices. A number of cardiovascular devices are visible on chest x-ray. Some of them are implantable and some are associated with monitoring and therapeutics. This is a cartoon of the heart. The blue side is the right heart, the red side is the left heart, and the tube at the top is the main pulmonary artery. Now, on occasion, we will put a very large bore central line into the right internal jugular vein and pass through it a balloon flotation catheter known as a pulmonary artery catheter or Swan-Ganz catheter. It goes all the way through the right side of the heart into the main pulmonary artery and then lodges in a distal segment of the pulmonary artery with the aid of a balloon. This allows us to measure several things: central venous pressure on one side, pulmonary artery pressure on the other side, the wedge pressure where we measure what is thought to be the left atrial pressure by a column of blood when the balloon is inflated, mixed venous oxygen saturation and core temperature. We can also do thermodilution to measure cardiac output. The correct position of the pulmonary artery catheter either looks like this, where it opens up in a V, or crosses back over like this. In my experience, most of the time, this is the picture that you see. So let's have a look at a couple of x-rays of pulmonary artery catheters. In this picture, the patient has a pulmonary artery catheter in an ideal position. There's a large bore central line in the right internal jugular vein, and the PA catheter has been placed. It is looped around and it is pointing down into the lower zone of the right lung. Note also that the patient has a left-sided central line, and if you look very carefully, there is an NG tube still in the thoracic esophagus. There is a pulmonary artery catheter also in this picture. Now, where we don't want to see the tip is in the upper zone of the lung, because airway pressure would be too high there. The other place you don't want to see the PAC is curled up inside the right ventricle. What is this device? You can see this patient has a PA catheter. They also have an endotracheal tube in place, and they've had a sternotomy. So this is a post-operative cardiac surgery patient. But if you look carefully, you will see this line. And it ends in a radiolucent tip. What is this? This is an intra-aortic balloon pump. They're used to support the perfusion pressures of the heart and brain by a balloon inflating in diastole. These are often placed following myocardial infarction or following cardiac surgery, and the idea is to drive up diastolic pressure, perfuse the heart, and improve overall cardiac performance. The intra-aortic balloon pump must be placed beyond the left subclavian artery, or it will cause ischemia to the left arm. So there's the left subclavian artery, and it has to be placed distal to that point. If it's proximal to that point, that is problematic. In this case, the intra-aortic balloon pump tip is positioned too high. In this case, the balloon pump tip is positioned too low. Notice that there are three things here. The patient is clearly post-op cardiac surgery. There is an endotracheal tube. There's mitral valve replacement. And what do you think this is? It's a pacing wire. And these are commonly placed post-op for cardiac surgery. What about this picture? This is a loop recorder. What about this? This is a permanent dual chamber pacemaker with the two leads visible here and here. What do you think of this? This is an ICD, an implantable cardiac defibrillator. The yellow lines represent the defibrillator coils. Between the lungs and the thoracic wall is the pleura. There's usually negative pressure in the pleura, and that's essential to ensure that the lungs inflate and deflate normally. This is a relatively normal chest x-ray, and we're going to look at some stuff that may collect in the pleura that you need to be able to see when you're doing your initial chest film. If air becomes trapped in the pleural space, for example, the pleura is damaged by a broken rib, a ruptured bulla, or a central line, air collects in the anterior apical part of the chest, and we call this a pneumothorax. The lung itself is a little bit hyperdense, and there is often a lung edge that's visible. Beyond that point, the lung fields are unusually dark, and you can't see any lung markings. If air continues to collect without being drained, the mediastinum moves in the opposite direction, and we call this a tension pneumothorax. If blood or fluid collects in the pleural space, it drains to the posterior dorsal part of the chest, and it appears radio-opaque or white, often with a meniscus. This is a pleural effusion or hydrothorax. Occasionally the liquid is blood, and we call that a hemothorax. Now let's look at a few examples. What's going on here? Take a moment and have a look at the picture. There is a pneumothorax present. Note that the mediastinum has shifted away from the pneumothorax. As a consequence, we call this a tension pneumothorax. What about this picture? Look carefully and you will see that there is a left apical pneumothorax. In this picture we have two anomalies, bilateral pneumothoraces, one on the right and one on the left. To capture a pneumothorax, it's important that the patient is sitting upwards. If they're lying flat, you have to be careful because air moves along the path of least resistance, so the air can be in a sulcus between the lung and the diaphragmatic pleura. This is known as the deep sulcus sign. The treatment for pneumothorax is to place a chest tube. This is the fundamental idea. We'll start with a cylinder and we'll partially fill it with water. So we have liquid here and air here. If we want to drain the liquid, we will place a drain in the bottom. And if we want to drain the air, we need to put the drain where the air collects. And that is at the top. So let's see how this works in practice. The purpose of chest drainage is to remove the material trapped in the pleural space. As air rises to the top, to drain that pneumothorax, the chest tube is inserted posteriorly and to the apex of the lung. For a pleural effusion, the chest drain is typically inserted into the bottom of the lungs. Again, fluid is affected by gravity. Here is a chest tube in situ. Note the lung edge. I'm going to zoom in on this. There are two drainage eyes in the chest tube. Here they are highlighted. Both of these eyes need to be inside the pleura for the chest tube to work effectively. If both eyes are not in the chest, then air can leak into the chest wall and cause significant subcutaneous emphysema. In this situation, the patient has a pneumothorax. A chest tube has been placed. You can see the tip of the tube, but you will also note that the pneumothorax has failed to resolve. The reason for this is the second eye is outside the pleura and air is escaping from the lung into the subcutaneous space, so the patient has a huge amount of subcutaneous emphysema. The tube needs to be reinserted correctly and perhaps placed on some negative pressure. I showed you this picture earlier, a pneumothorax associated with a central line. You've just put this central line into your patient. It's a right-sided internal jugular line, and you've carefully evaluated the right lung for pneumothorax, and you're very happy with yourself. However, make sure that you don't miss the pneumothorax on the other side. That was entirely coincidental. This is a patient post-cardiac surgery. Everything looks fine here. But several hours later, the patient desaturates and his airway pressure increases, and this reveals a pneumothorax on the right. This is a common phenomenon whereby the airway pressure suddenly rises in a patient who is ventilating normally, and in that scenario you should always think about pneumothorax. For this patient, it was easily resolved by placing a chest tube. Now let's review this tutorial. In this tutorial, we looked at chest imaging in critical care, looking at hardware, specifically looking at the position of hardware and malpositioning. I started with a discussion about endotracheal tubes, where they need to be placed above the carina and what happens if they are pushed in too far into one of the main bronchi, usually the right main bronchus. Then we looked at central lines, including pulmonary artery catheters and PICC lines, and where they should be inserted into and where not, followed by cardiovascular devices such as pacemakers and intra-aortic balloon pumps, and we finished the tutorial with a discussion about pneumothoraces and chest drains. Next time we're going to look at common lung pathologies on the chest X-ray in the ICU. Now that we've looked at the normal chest X-ray, lobar collapse and consolidation, and hardware, in the next tutorial we're going to look at different pathologies that we may encounter on chest imaging. If you're enjoying these tutorials, please subscribe at CCM Tutorials or follow me at ccmtutorials.org. Leave me some likes, tell your friends about me, and leave some comments. I'll see you soon.